if you're in the private sector, I'll also show you some algorithms from the HIV Clinician Society so that you can be able to do the right thing for your patients. So yeah, let's proceed from there. Initially, I thought that I was going to review a lot of studies, but I thought we only have, 1 hour, 30 minutes. I actually must say it's likely that we will use all of it without going through some of your questions. So please forgive me already, as always. But just as a summary slide, TLD is now the preferred first line ART regimen in South Africa. When I say TLD, I mean a tablet that has 3 drugs, so it's a fixed dose combination. It's taken once a day. It's got the T is for tenofovir, the L for lamivudine, and then the G there for, yes, I see that I wrote DTG, I don't know what I was writing there. Oh yeah, DTG is the actual drug. Okay, I think we are together. So TLD, T for the tenofovir, the L for lamivudine, and then the D for DTG. I almost gave you what DTG stands for, but it's fine. So that is a standard, that TLD is our preferred first-line ART regimen. But we have a number of studies now that allow us to use the same regimen for second line, and if not, even for the third-line ART regimen. And these are some of the studies. If you have time, just Google them and read about them. We've got the Donny, we've got the Nadia, we've got the Artist. If you review these 3 studies, you're going to see that TLD is now actually the first choice, even for second line therapy. And you would have seen that tenofovir and lamivudine, they are now recycled or maintained across the different regimens. So if a patient we are seeing them for the first time, they will get tenofovir and lamivudine. If they need second line, there's a very high chance that they will get tenofovir and lamivudine. And even when they need third line, they are likely to be, on a similar regimen, right? And then also we now know that even though our protease inhibitors are generally having a very high barrier to resistance, they are very potent, but DTG has come up tops in terms of whether people are able to tolerate the drug in terms of side effects. So it has a better side effect profile, but DTG, in as much as we trust it as a very good drug, it should never be used alone. And if you can just check the Domono, study there and read about it. So everything we are going to discuss is based on, what these studies have found, and this is what has informed our South African guidelines up to now. So in terms of resistance management, we do not talk about DTG resistance before we do the resistance test. Generally, we don't transition and we don't change patients who are on a DTG-based regimen unless if you are able to confirm that there is high level resistance to the drug and therefore we need alternate regimens, especially because DTG resistance is rare, right? And luckily, we do have a backup. Should we have a patient who has high level resistance or whose virus has a high level resistance to DTG, we have some backup. And these are again, our fallback superior drugs, which is our protease inhibitors, but it should always be in combination. And on your right hand side, then I was trying to show you, what the science says and how it's applied and how then it has informed our guidelines. So our guidelines are now informed by these studies, and we also have local studies, which have been done and have replicated what has been found internationally. So we know whatever has been found wherever is also applicable here, and we have protocols. And obviously, in our setting, we have to consider the limited drug options that we have. There's many new drugs that we still don't have here, in South Africa. So the algorithms, as I'm going to share with you, they've taken that into account, and then let's see then how that goes, right? So I'm not going to spend a lot of time on this, just to say that for you to understand resistance, generally speaking, you have to know the HIV life cycle. I'm going to spend probably just 2 minutes on it, just to say that, you have your HIV virus on your left-hand side there. It's got a nuclear capsid. You know, the two yellow things there are the two strands of RNA. So HIV is an RNA virus. Me and you, we are DNA species, right? So very, very important. And then the blue, what you see there, it's a cell, an immune cell that expresses a CD4 receptor. So it's a CD4 cell, you know. And what I really need you to appreciate is just 5 key steps of this HIV life cycle. I know if there's a virologist, they'll probably tell us about 100 more things that are happening on this slide. But I need to just say, when HIV infects our cell, the first step is attachment. So one of the glycoproteins, which you've these red lollipops, which are popping on the membrane of the virus, these are glycoproteins. There's GP120, GP41. You don't have to know that, you know, but GP120 will attach to your CD4 and your CCR5 core receptor. So that's the first thing I want you to know, that there is attachment, right? The next thing is that the membranes of the two cells, okay, yeah, I'll say our immune cell and the virus are going to fuse, right? So the second thing I want you to know is fusion. So you have attachment of the virus, you have fusion of the membranes. If fusion happens, the viral genetic material, the viral genome, which is generally the two strands of RNA and three key enzymes, are released in the cytoplasm, as you can see there. And the viral RNA, one of the strands, as you can see, it's going to be converted to a double-strand DNA. That is the third thing I want you to know, is reverse transcription, right? The transcription when RNA is converted to DNA, because there's a very important enzyme that facilitates that process. It's called reverse transcriptase. Okay, so we attach, we fuse, we convert RNA to DNA, and that DNA will then be transported into our nucleus, right? That is where the danger happens, because once that happens, the viral DNA, the DNA of this bug, is going to be inserted or integrated into our DNA. And that is what we call integration on top there. Integration. So that's the fourth thing I need you to know. Attachment, fusion, reverse transcription, which is the conversion of RNA to DNA. The DNA is transported into the nucleus. There is integration. Just imagine, as far as I know, my DNA is my DNA. Imagine if in the code of the Mawela DNA, there's a Mazibuko DNA. When I try to make kids, I'm thinking I'm making the little Mawelas with a forehead like mine. Boom! They all look like Mazibuko. What did Mazibuko do? He has captured my DNA, inserted his DNA into my DNA. When I try to reproduce, because remember, our immune cell during mitosis, it is trying to produce more of itself, more CD4 cells to respond to the infection. Unfortunately, as it does that, there is the code of the virus, right? So during replication, you know, this DNA, our DNA will be converted to messenger RNA to form these polyproteins here. These are proteins that are going to form part of a budding virus, right? And at some point, they need to be cut, you know, like a Caesar. If you think of a Caesar, cleaved, that's the right term that is used in the textbook, by an enzyme called protease. So protease cleaves, cuts these proteins. If they are cut, they are allowed to form baby viruses, and they are allowed to mature and go and infect more cells. Attachment, fusion, transcription, integration, and cleaving by protease, right? Hence, in the last slide, which I'm no longer going to talk about this, I just wanted you to see it, that where our drugs work, our drugs rely on specific things that need to be in place. So if you look at our entry inhibitors, Maraviroc, it's a drug that blocks your CCR5 co-receptor there so that attachment doesn't happen, right? Obviously, if there are changes in the GP120, Maraviroc won't work, right? The same, when we say fusion, there are drugs that block the fusion or the joining of the two membranes. One of them is fusion or T20. The actual name is enfuvetide. You don't have to cram it. But if there are changes in the fusion domain or in GP41 from the viral side, that drug won't work, right? I said there's an enzyme here, reverse transcriptase, RTI, reverse transcriptase, the R and the T there. This enzyme facilitates the conversion of RNA to DNA, right? If there are changes in this enzyme, our drugs, our nucleoside reverse transcriptase inhibitors, tenofovir, abacavir, zidovudin, lamivudin, emtricitabine, and in today's world, tenofovir and lamivudin are like the core of our regimen. These drugs may not work if there are changes there, right? Again, there's an enzyme called integrase. There are drugs that can inhibit integrase, the enzyme that facilitates the viral DNA, Mazibugo's DNA, from getting into Mawela's DNA, right? They are called integrase inhibitors like dolutegravir, cabotegravir, elcitegravir, mawelategravir. As long as there's a tegravir, it's probably an integrase inhibitor, right? But you understand that if there are changes in this enzyme, which is supposed to be inhibited by these drugs may not work. The same protease inhibitors must cleave, you know. So why do I keep on saying if there are changes? Because that is what resistance is. At the end of the day, when we say resistance, we mean there was a mutation in the virus which gave the virus an advantage such that the drugs we use cannot work. It means there are specific changes on their target areas, right? A number of things may potentiate or make resistance to be feasible. Drug interactions, which me and you are responsible for, rapid clearance, which is more a biological thing, poor absorption of the drugs. Again, it could be facilitated by drug interactions. A pregnant lady who's on TLD, who's got the heartburn, and she decides to take myogel, Gaviscon, maybe there's magnesium, aluminum in there. They attach to DTG, forming complexes. Rather than being absorbed, it is released with the poop, right? Those are some of the things. The genetics, things that we have no control over. Wrong dose, it's me and you. Poor potency of the drugs, again, it's me and you. If we're not giving the right regimen, monotherapy, or our drugs are not stored properly. Poor adherence, which is things most of the time on the patient side. But when you look at social issues, hunger, poverty, people have no control over those. At the end of the day, anything that leads to insufficient drug levels or which allows the virus to start to replicate in the presence of suboptimal drugs is going to lead to the or give a chance to this virus to transform, right, and for survival. And when that happens, we have mutations and our drugs stop working. Some people, unfortunately, they do not go through any of this. This is what you would call acquired drug resistance. Someone who started ARVs without any mutations, and on their journey on ARVs, they start to develop mutations, right? On the other side, a new person who has never been on ARVs may have a contact, or let's say sexual contact in this instance, with someone who's treatment experienced, someone who's already on third line with a high viral load. They have sexual contact. They then become infected with a very bad bug from day one. So those are the sort of two kinds of transmission. It's either you acquire it whilst you're on treatment, or you are infected with a resistant bug from the start, right? There was an ACC training program here in Gauteng, which I was invited to give one or two topics, and I also shared this about the virus. So I spoke about our clinical practice as a contributor to resistance. I spoke about patient-related things. It's also important to know that the virus itself, right? The virus, there are features about the HIV virus that make it prone to mutations. And mainly because of that enzyme, reverse transcriptase, during the conversion of the RNA to DNA, a lot of mistakes happen during that time. And because that process is not error proofed, the replication, is allowed to continue even in that context. And therefore, at the end of the day, when you see a patient who's got a million viruses, these viruses are all genetically linked because they are probably from the same founder's virus, but they are all distinct and unique because of these ongoing mutations. Now, I did say that HIV is an RNA virus, and this is now what we say when we say it's an RNA. We mean something like this, right? This is an RNA, and if you look at it very carefully, an RNA strand is made up of these GCU. These are called nucleotides, right? And a combination of three nucleotides is called a codon. A codon only means that they have a code. A code for what? For a certain amino acid, right? Now, what are amino acids? I know some of you go to those expensive health shops and you buy amino acids, but what are amino acids? They are the building blocks of protein. It means you want to have some protein, those kinds of things. Now, it's important to know that GCU, that sequence, would code for a specific amino acid, right? Let's say that amino acid is mawela, for argument's sake, right? If there is a change, if at a specific area of this strand where we expect GCU, we expect this code to code for a specific amino acid to give to a certain structure of the virus. But there's a change in terms of G, let's say it's another C. So GCU becomes CCU. The amino acid is no longer mawela, it's mazibu, for argument's sake, right? Therefore, a mutation has happened. That means there's going to be a structural change in a certain area of this particular virus in this instance. And this change may favor the virus or it may disadvantage the virus. So mutations are not always bad, right? It's for survival in that space. If you look at here, this is a codon. It's made up of three nucleotides, AUG, right? But you can see these three code for, okay, the actual amino acid is methionine, right? As you see there. I don't want you to focus on the big words. That's why I don't want even to use them. I just need you to grasp the concept, right? That a combination of three nucleotides code for a certain amino acid, methionine. If this code changes, it will then code for a different amino acid. Here in this instance is alanine, for example. That has big implications, and let me show you how that works. So one of the mutations which is common, mainly associated with patients who are taking a regimen that has lamivudine and emtricitabine. When you read your resistance results, which I'm going to show you later, they will say we have picked up a reverse transcriptase inhibitor mutation, and this mutation is M184V. That's what they tell you. Now, let me go back to my previous slide. What M184V means? It means when you pull this strand, you see this RNA strand, and you pull it like this, right? You have the first code number 1, code number 2, code number 80, code number 100, code number 150. When you get to code number 184, you are expecting nucleotides that code for methionine, right? Unfortunately, whatever is there at code number 184 is no longer coding for this amino acid. It is now coding for valine. So things have changed. As soon as you change an amino acid at a specific area of your DNA, there's going to be something that's going to be different about this baby who's going to come. Okay, so that's how you interpret the if they say K65R, they mean at codon number 65, K is replaced with R. Basically, that's how. And today it's a webinar. If it was a training, I was going to show you what K is and wow, 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 wow. But we don't have time, right? So let's look at this, and maybe I'll give you 30 seconds to participate. So a 34-year-old patient with HIV comes to you after being on treatment for several years. Previously, they received a regimen that had a boosted atazanavir, tenofovir, and emtricitabine, and experienced 2 times viral loads more than 1,000. In this instance, wherever this was, they did a genotype, okay, which showed only reverse transcriptase mutation. M184V mutation is what they saw. So let me run a poll. Let me see if I can run it because I'm a lone ranger here. So which of the following statements is true regarding this M184V mutation? If you see it, must you be happy? Must you run? What must you do? Should you be worried? Should you be okay? If you are new to the HIV world, worry not. I'm gonna explain it, but give it a try. What do you think? Is this a bad mutation? Is this something we love? Which drugs does it affect? Okay, 2 more seconds because we have a long way to go. I'm going to stop and then show you the results. So 40% said D, which is that the M184V mutation causes increased susceptibility to tenofovir and zidovudine. Is it true? Is it not true? Okay, let's look at it together. So if you would want to be coached and you are a medical officer, you want to write the diploma in HIV, this question is from the practice exam that I used to prepare. Once we have done all the theory, I take the colleagues through these things and they go through it. So it's an example from our coaching program. So what is the impact of M184V? If you see it, what does it mean? Okay, look at just this green. Forget the sentences there. Green means sensitive, red means resistance, and they've given you a number of drugs. If you see this M184V, there's going to be high level resistance to lamivudine and emtricitabine. It's a tick, right? Then abacavir is its effectiveness is reduced a little bit. It's yellow, no, it's not red, so a little bit affected. But look at tenofovir. Remember, this is normal. So if it moves this way, it means it becomes more, the virus becomes more susceptible, more sensitive to tenofovir and zidovudine. This is important. That's why lamivudine and emtricitabine, right, are always in the regimen. First line, lamivudine is there. Second line, lamivudine is there. Third line, lamivudine is there. Why? Because mutations are only expressed as long as the patient continues to take the drug that is associated with that mutation. We know that M184V only develops if you take either lamivudine or emtricitabine. But we love this mutation. Because we love it, we want to keep it there. Even if these drugs are out, we are not going to get any effect from them. But by keeping your patient on these two drugs, lamivudine or emtricitabine, the mutation remains expressed. As long as this mutation is expressed, two things are happening to the virus. Firstly, it becomes less fit. The virus replicates very slow in a sluggish manner. By just maintaining the mutation, it's a very slow virus as long as it has this mutation. Number two, it increases the susceptibility or the sensitivity of tenofovir or zidovudine. That means now we allow tenofovir or zidovudine to just finish off this virus. It finishes off, very quickly. Okay, so that is the science behind keeping patients on lamivudine even when there is high level resistance against these two drugs. So you shouldn't find yourself prescribing a 3-drug regimen that does not have either of the two. There should always be lamivudine or emtricitabine. Okay, I hope that one is clear. Let's go to our second scenario. A 20-year-old man is newly diagnosed with HIV during the past 14 months. He had intermittently taken pre-exposure prophylaxis, so he was on PrEP, oral PrEP, and then his studies showed that his viral load was 27,000. So he was started on an ART regimen, tenofovir, lamivudine, and DTG. He has never received cabotegravir. Don't worry about that part. Right. The baseline resistance comes 2 weeks after starting him on TLD, right? And it shows only one mutation. Oh, two mutations. K65R and M184V. Nah, I know for now it's like, hey, what are these codes all about? But anyway, let's run the poll and then give it a try, and then I will take you through. But if what do you think should happen? So to summarize this case, it's someone who was HIV negative, right? And they were on PrEP, two drugs, tenofovir and amivudine, to prevent HIV. Unfortunately, for whatever reason, they became positive, and they have these two mutations, right? What must we do? What must we do about this situation? Must we stop TDF? What must we do? Yo. Okay, but as you answer, what I can tell you is that M184V is a signature mutation, right, for lamivudine and emtricitabine. K65R is a signature mutation of patients who have been taking tenofovir or sometimes even abacavir. But TDF and TEF, that is a mutation you would get if the virus is exposed to TDF and it's allowed to replicate, without an effective regimen. So it's that kind of thing. So let me see. I see 34. I say it's mixed, né? But 34% are saying. I'm just looking at the dominant answer. 34% are saying continue the current regimen. Other people say TDF is no longer working. If you are saying TDF is no longer working, it means you were trained HIV medicine during my times where we used to think if there's K65R, you must stop TDF. But F is the most probable answer that you must give in this instance. We now have multiple studies, and some of them I mentioned, the Nadia studies and those kinds of studies that shows firstly that you shouldn't worry about M184V, right? Because it's a preferred mutation. It makes zidovudine or even TDF in that regimen to work best, right? The Nadia study has showed us that regardless of the presence of your K65R, right? Regardless of your K65R mutation being there, tenofovir must be kept in that regimen. It still works in that instance. So the presence of M184V or of K65R has no impact on our ability to use a TDF on first line or second line, right? However, our guidelines will always recommend that you start these patients on TLD. Hopefully at 3 months they are suppressed, then you are happy. If they are not suppressing, then you might be looking to do your resistance test, and it's one of the indications in our guidelines. All right, so these mutations will be there, but you have to interpret their clinical relevance for your patients. All right. Another case, 23-year-old man with a CD4 count of 386 took ARVs, TDF, TEE, as we used to call it, tenofovir, emtricitabine, and efavirenz, and did well for 18 months and was assessed. But he had a 6 months period where there were issues, poor adherence, and ended up with multiple viral loads above 8,000. Okay, a genotype was done. It was probably in the right country to do it. Here we don't do it for efavirenz. But anyway, they found M184V is the mutation they found. They also found K103N. Okay, so which of the following statements is true regarding K103N? It's just a game, colleagues. We are having fun. So don't worry about the correctness of your answer. Just enjoy the ride. There. Ooh, look at the time. Okay. Let's go. Let's go. We'll see how far we go. I always over plan because I like teaching, not the webinars. But let's see. Okay, I'm going to stop. 56% says K103N indicates high level resistance to efavirenz. Coolies. Awesome. I fully agree with you. So basically, if you are in the HIV world, there's many mutations. Many, I can tell you, there's millions and millions of mutations. But you just need to know M184V, K65R, K103, and though we no longer use efavirenz anymore, but the key thing about this mutation is that it affects the whole class of your NNRTIs. Some of the third generation NNRTIs like doravirine will be spared. This mutation would not affect doravirine that much, but our commonly used NNRTI, nevirapine, and efavirenz would be totally out, and most likely rilpivirine, eltravirine will be compromised, not necessarily totally out. It depends on if there's any additional mutations in that space. So generally speaking, it affects our NNRTI. Okay, let's do another case, then I'm gonna share with you further things. Now, this one is linked to why we are here tonight, isn't it? So it says a 37-year-old lady presents to a clinic for follow-up. She has been taking ARVs, tenofovir, emtricitabine plus dolutegravir for 2 years. The viral load is 1,800. Which of the following is true regarding resistance to DTG? You see, if you pass this one, we stop this webinar. It means this webinar is not necessary. Yo, but it's a horse race what I'm looking at between A and it depends when I stop. If I stop now, A wins. If I stop 2 seconds later, D wins. Guys, let's have fun and don't worry. Okay, I stopped at the right time because I'm telling you, it was so close. But to be honest, let's see what A says. Integrase resistance analysis is a standard part. Yeah, A, it depends when you would have answered. Initially, it was not part of a standard. When you ordered a resistance test, you needed to tick that you also want them to evaluate integrase resistance. This is because we believed at that time that it was so rare. But I understand that our lab currently, if you order a resistance test, they would do even your integrase resistance same time. Ne? B has mutations that may affect DTG, even C, but these mutations, they are neither here nor there. But I can tell you, D is the most important thing you need to know. Remember, I said you must know M184V, you must know K65R, you must know K103N, you must know G118R. Please write it down. G118R. And why is that? Let's continue learning together so that you can understand, because now we are getting into specific things there. DTG resistance, right? And if you look at most of the studies, they always talk about DTG resistance being linked to DTG monotherapy, and the whole thing is around whether as you give dolutegravir, your NRTI backbone, is it very strong, you know. And with TDF, luckily, the Nadia studies have saved us to say if you give DTG with a tenofovir lamivudine base regimen, you get the same outcomes, even if you were to give alternate NRTIs. And because TLD is available as one tablet, easy to take, therefore it becomes very easy for us to say no, let's give TLD first line, second line. The side effect profile, etc., is better. Even the frequency. If you had to give zidovudine, you're looking at, a BD dose, etc., etc. But sometimes we apply what we know about tenofovir to a drug like abacavir. If you read some of the literatures, they don't like giving abacavir when there's certain mutations. I mean, if you have M184V and K65R, you know that both mutations would reduce the effectiveness of abacavir. And we do not have studies that confirm that we can recycle abacavir. If you look at our guidelines, we have taken what is applied in the adult program about TLD, and it's being applied to abacavir, you know. And maybe that's why we do have some children out there on DTG who are not suppressing, because they are on abacavir and maybe the DTG is left alone, you know. So I know me and you, there's no way that we could give intentionally a patient, you know, a monotherapy. But this is a clinical monotherapy where the patient is taking a tablet that has 3 drugs. But the question is whether these other 2 drugs given with DTG, are they strong enough to protect DTG as well, you know, for the longest, particularly people who have history of failing other regimens. You know, if you are giving TLD to someone who has failed other drugs, it means they have a lot of mutations which will impact on your backbone, the NRTI backbone. If it becomes too weak, basically, it's like clinically your patient is on monotherapy, and DTG may suppress, but it may also fail to suppress such patients. And we see it today with the rising number of patients presenting with DTG, even when we thought this drug was very good. This is an example. These are not my slides. They are from the NHLS, and this is Dr. Kim Stegen's slides, and it's Chris Charlotte Maceke there. And just to give you an idea that they evaluated 162 specimens that were sent through for resistance testing, of which 43 of these specimens had required that they check for integrase resistance. You can see that predominantly these were females. The majority had a viral load way above 10,000. Remember, 4 logs, it means there's 4 zeros after a one. I don't know if Dr. Boy's here. I was asking her the other day. You know, most of them had taken an integrase inhibitor for more than 2 years. You know, if you look at prior exposure to protease inhibitors, about 55%. You see why I'm talking about this. It means these are people who were treatment experienced, right? Who were on ARVs before, who have previous history of high viral loads before, right? Because if you add 55% plus this, it means over 80% of these people are people who are exposed, who are known to be on ARVs, and probably it means they had failed these regimens or they had high viral loads on these regimens. It depends on our documentation when we do these things. But in the red block there, you can see of the 43 there, of the 43, 39 had DTG resistance. Obviously, as a total, you'll say 24%. But if you look at it as a subset of people where integrase resistance was done, this was very, very, very significant, right? And most of them, it was DTG related, though some of them had exposure to some of the other what you call integrase inhibitors, raltegravir, cabotegravir. And obviously, if you fail those drugs, you may end up with mutations that may affect our patients. Here is a list, you know, of patients and the outcomes. What I need you to pay attention to is just 2 things right here. Number one is that there are mutations that are known to not cause serious resistance on their own. Let's say you have a patient who comes in and they have E138K on its own. On its own. I don't know if we have anyone who had that. Okay, let's use R263K, right? You can see that those who had that mutation on its own, they will have low or if not intermediate resistance. And that's why patients who have these mutations, we still give them DTG, and most of them will resuppress because DTG is so good. But 2 things I need you to pay attention to is when these weak mutations are like 3 or 4, right? In combination, as you can see, 1, 2, 3, 4, 5. now you have high level resistance. And we know if you keep people on a failing regimen, that's why 24 months is what we have in our guidelines. But please let 24 months be 24 months. It shouldn't be 3 years, 4 years, 5 years, because now you get more and more mutations happening, and it will render the poor dolutegravir fully ineffective. So that's the first thing I want to say. Hence, in Western Cape, they have a guideline now that actually we should be testing earlier, which I won't cover here. But there's now a general agreement. Even our national guidelines may change and say some group of patients, if they have a high viral load, even if it's at 10 months, you might need to consult an expert to make a decision to evaluate those patients and not wait for 2 years. 2 years can be far. So the first thing is small mutations in combination become a big problem. The second thing, if you check carefully, there's a specific mutation whenever it appears, whether on its own or in combination, is high level resistance. Have you picked it up? I said you must know it. What mutation is that? G118R. It's, I don't know if this is orange or brown. Let's just say for today it's brown. Do you see G118R? Whenever you see it, there's high level resistance. Even when it appears on its own, there is high level resistance. This is the single mutation that you don't want. You don't want to see. You don't want your patients to have it on a dolutegravir based regimen, because whenever it appears, DTG goes to its weakest. Okay, so that's why I said that is one mutation you should know. The rest on their own is neither here nor there, but in combination, they can still render the drug to be fully out. So I thought this was important for me to share with you. So the key mutations is R263K. I won't be reading. Just remember, patients do develop these mutations, but if actually this one works like M184V, it actually makes the virus to be less fit, and therefore eventually these patients will be, that's why less fit these patients will suppress. E17Q, is low level resistance. It's probably patients who were exposed to other integrase inhibitors, but these patients with proper support, they do resuppress, unless if your patient develops this specific mutation G118R. If you see it, most likely there is what you call high level resistance to DTG, and your patient would not get any benefit from being kept on a DTG based regimen. So from the Clinician Society guidelines, there's then this nice summary of mutations. You can see M184V. You'll only see it if your patient is on lamivudine or emtricitabine. We want that mutation. We love it. Remember, I said mutations, some are good, some are bad. This one is good. We want to keep it there, right? TDF K65R, we love it. Well, we don't love it, to be honest. But TDF, if this mutation is there and you have a very strong foundational drug like DTG, you still give TDF, it will work, right? But pay attention, this does not necessarily apply to abacavir. I think this is where we have problems. With abacavir, we should try to always consult and see, what if there's anything we can do. The problem is usually there's nothing else we can do. So we don't have a lot of NRTIs. I don't know if you guys notice. We have one or two. So even if we know we shouldn't be recycling, we end up recycling. But the implications are we end up with children on DTG who are not suppressing. So, those are some of the issues we have. And then, like I spoke again about DTG, like generally high barrier to resistance, but these small mutations, 3, 4 of them can render the drug ineffective. So yeah, very nice summary for you. So yeah, I hope from here we can then get into the clinical issues to say, okay, now that I understand that DTG can fail, now if I have a patient with a high viral load, what is it that I can do? Okay, so number one, patients on ARVs must be monitored. You must do your viral load after 3 dispensing cycles, which is 3 months on a DTG based regimen, and again 10 months on a DTG based regimen. If your patient is suppressed, generally we don't have a problem. We start to be worried if the virus starts to be detectable above 50 copies. So if the viral load is above 50 copies, we need to respond by doing what we call ABCD, which is part of our adherence strategy, and I'll tell you a little bit about it shortly. But remember, we respond when the viral load is above 50 copies, but treatment failure, the threshold starts from a viral load of 1,000 copies. So if the viral load is between 50 and 1,000, we never use the language of treatment failure. All right. So basically, you have a patient who has a detectable viral load. You do your A, B, C, D, E, which I'll explain shortly. You repeat your viral load after 3 months. Hopefully it's green. That means your patient is suppressed, and you then support them. You buy them a cake, you celebrate with them. However, if it is still up, you need then to check, how long has my patient been taking ARVs? If they've been taking ARVs for less than 2 years, you then have to repeat the viral load every 6 months and providing enhanced adherence support, helping them to suppress by always reevaluating, do we have drug interactions, do we have infections, what else is happening, which may be contributing to the high viral load, right? If they've been on TLD for more than 2 years in the context of good adherence, you are worried. You must remember, TLD is a very good drug. Everyone who's adherent should be suppressing. If you have an exceptionally adherent patient on TLD for more than 2 years who's not suppressing, most likely there are mutations. You need to assess them a little bit more carefully. Are we together? Now, when I said A, B, C, D, I meant this. This is very important. Even when you request the resistance test, the form, the committee, they want to know, what have you done to improve adherence and other things. So when the viral load is high, we are asking, is my patient taking the drugs? Do they have the necessary support? Have they disclosed? How do they remember to take their drugs? Do they have an infection which may raise the viral load a little bit, which we need to treat? Yes, they are taking the drugs. Is it the right regimen? Is it the right combination? Is it the right dose, especially for children, right? Drug interactions. Are they taking Gaviscon? Are they using something to clean the tummy that has a lot of magnesium? Are they on calcium? Are they on iron supplements? Have they taken TB treatment recently? And me and you, we forgot to adjust the dose to counter for the effect of rifampicin on the regimen. Is this a patient who needs a resistance test? Is this a patient who has taken TLD for more than 2 years? Where all these things are negative, they are exceptionally adherent, but the viral load is not going down. So once you have two or more viral loads more than 1,000, right? And the patient has taken your ARVs for 2 years or more with good adherence. And this patient is a TLD2 patient. TLD2 patients are these people, when they started TLD, they were not new. They knew ARVs. They had been on lopinavir. They had been on efavirenz. They at some point they were on stavudine. So any patient who has had a high viral load more than 1,000 whilst on ARVs, even if it's a single viral load, you would classify them as TLD2. Remember, the issue of TLD1 versus TLD2, right, is not an issue of whether first line or second line. It's about risk. A TLD2 patient has a significantly higher risk of failing a DTG-based regimen compared to a TLD1 patient. That's why everything that is blue here is referring to a TLD1 patient where we don't expect them to fail. And even if you request a resistance test for a TLD1 patient, It must be an exceptional situation. Maybe it's a child who got infected via a failed VTP or PMTCT. Maybe the person is TLD1, but they were on PrEP and maybe they became positive whilst on PrEP. Or there's a history, they are TLD1, but there's a history of taking other things, drug interactions, which could have rendered, the levels of the drug to be lower. So there must be an exception situation for a TLD1 patient to be done a resistance test, right? But for the majority of patients, it would be a patient on TLD where the viral loads are remaining high. They've been on it at least for 2 years and they are adherent. You have to discuss with an expert for a resistance test, and that's where it works. Even from the private sector, this is from the HIV Clinician Society. Their algorithm is simple. It just says if the viral load is more than 50 copies and the person is either on a PI or on a DTG regimen for more than 2 years, and you have addressed adherence and it remains high, right? Perform a resistance test. It's just a simple algorithm, not complicated, right? In our guidelines, you'll find these indications for doing a resistance test. Again, on a protease inhibitor-based regimen for more than 2 years, where the viral load remains high, do it. On a DTG-based regimen for more than 2 years with good adherence, do it. Where there was drug-drug interactions, concurrent rifampicin, anticonvulsants, anti-acids, etc., and we didn't make any adjustments. It's an indication for that. A patient who would have had a chance for where their HIV would have been exposed to a suboptimal regimen, like 2 drugs or even 1 drug, especially in the PrEP context, there may be a consideration to do a resistance test if they are failing to suppress on TLD. So these are like your 4 key bullets that are very, very important. So I'm just going to run quickly through then the principles of doing this valuable test. And just to say that few things are important. When you look at this diagram, comparing your left-hand side to your right-hand side, here you have a lot of red viruses, here you have a lot of yellow viruses, right? A resistance test should be done on this side versus on this side. And what is the difference between the two? On your left-hand side, it's a patient who's got a sensitive virus, the red ones, and a resistant virus, which is the yellow ones. They are not on treatment, right? They are not on treatment. There's a basic rule about resistance testing. Don't do it if your patient is not on the ARVs or there's poor adherence. You would rather tell them to go back, take the drugs, and come back whilst taking the drugs and do the test. Because if they're not on ARVs, the sensitive virus becomes the most dominant virus. You are going to waste a lot of resources. One test it's about 3,000 rands to do one resistance test, by the way. 3,000 rands. If you do it here, your results are going to say sensitive, sensitive. There's no resistance, right? If your patient then takes their treatment and the viral load is detectable, it's above 1,000, but they are taking their drugs. The drugs they are taking every day are going to suppress the red ones, the sensitive ones, and filter only your resistant bugs here. If you take blood at this point for a resistance test, it's going to pick up the mutants and tell you which mutations are there. So whenever you do a resistance test and the result says sensitive, it could mean two things. It could mean that the patient has no resistant virus, or they do have a resistant virus, but you did the test when the patient was off the drugs. So it's a very important principles. Why is this important? Because this test can only detect mutations that are causing resistance to the current regimen. This is very, very important. When you look at those results, don't just look at them and say, oh, it says sensitive to efavirenz, I can give efavirenz. No, that's not true. it will say sensitive to efavirenz because at the time when you did the test, the patient was not on efavirenz. As soon as you give them efavirenz, KY03 is going to show up. So it's very, very key. Now, it can also help to conserve treatment options by showing ineffective, you see, the resistance results can you the only thing that paper shows you is the drugs you should not use, the drugs you should not use, not what you should use. So if there's a drug there, let's say DTG, and it says high level resistance, the result is telling you you cannot use DTG for this patient. But if you see lopinavir sensitive, sensitive is not equal to the drug will work. Okay, so that's very important. And then basic things in South Africa, you would not be approved to do a resistance test if the viral load remains less than 1,000 copies. It must be above 1,000 copies. And it says here it cannot detect low frequency mutations less than 20%. That's why I was showing you this. Even if these mutations here are present, but they are now in a minority, the resistance test will not pick them up. Make sure your patient is adherent so that the resistant virus becomes visible. It becomes the dominant virus in your patient's specimen. Then you win, right? And then it will only show currently circulating strains, yes, based on the regimen that the patient is taking. That last bullet, this bullet, I can even stop here if you get this one. It is better at telling you which drugs won't work, not which drugs are going to work. Please don't forget this part. This is very, very important. So sensitive is not equal to the drug is going to work. So pay attention to that. So how to do the test? This I have addressed, right? So the part that I want to emphasize is that is the bolded part. The patient must be fully adherent on the current regimen. They need to take the drug. Don't do the test if the patient has stopped. You know, you would rather ask them to go and take the drugs for at least a month, and then next month when they tell you I've been taking, I have not missed a dose, then do the test. Otherwise, you are going to be very wasteful. To do the test, you need 2 purple tops, very important. If it's on a Friday, make sure that this specimen can get to the lab. They don't like aged old specimen, so try to make sure that you call the lab and say I have an urgent specimen, it needs to go. Make sure you write the information about not just the current regimen, the history of the regimen, you know, that the patient is on. Specify that you want integrates, but I understand that at this point they will do it. There must be the phone number of the doctor and the email address, please. Otherwise, they will reject the specimen. But it doesn't mean the patient must move from your clinic to a centralized hospital. Just call the hospital, explain, and then if the doctor says yes, let's say Ekuruleni, you call Dr. Ben there, you know, and then he authorizes, you put his details there, they will process that, right? This bullet here, even if the machines have improved and they can detect mutations even at a very lower viral load, in South Africa, if the viral load is not above 1,000, generally it would not pass this thing, right? So very, very important. And please note, sometimes the rejection has got nothing to do with you. Sometimes as they process, they fail to amplify the DNA of the virus so that they can look at it, right? And they will tell you that amplification has failed. So very, very important. So yeah, just to summarize, the patient must have taken adequate ARVs for at least 4 weeks. You want to make sure that the resistant virus is the most dominant. It takes about 21 days to get the results. But if it's urgent, like it's a pregnant lady, call the lab. Look at the price. So you can't afford to do it when maybe you're going to get funny results. Potential results, they can tell you that there is low level resistance. So this means the drugs may still work, but generally it would mean that you must apply to the third line so that you can get help. If the results are susceptible, third line committee does not review results for high viral loads where the results tell you that the drugs are still working. So you just need to continue the regimen and provide adherence. Don't send susceptible results to the third line committee. They want the resistant results. Then they can tell you that poor sample quality, that means you have to repeat. That means maybe you drew the blood on Friday, you send it on Monday, you'll have to repeat. Again, your patient might even start to become sick. So try to do it correctly. If you get a no amplification, it means you didn't do anything wrong, right? They just couldn't amplify. I know they still give reasons, hemolysis, what, but generally I take it as a lab issue. But I know they will disagree with me if they are here. In any way, I don't work in the lab, right? So yeah, examples of the results. Look at this. ARV treatment regimen, you didn't complete it. Me and you, we didn't complete it. This is important information which helps in terms of the virologist interpreting the results, right? No amplification obtained, either because of an old specimen or because of a lab analysis. The test failed, basically. So you can see then they couldn't process. So repeat, 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 which is delays again for your patient. Now, if you look at this one, they did everything, but it's susceptible. So if it's susceptible, don't send to the third line committee. And remember, I said susceptible can mean two things. Either your patient has a very sensitive virus, there are no problems, or at the time when you did the test, they had stopped taking the drugs. So you need to check your patient and ask them what's happening. If you see something like this, you are a little bit worried. You can see your NRTIs, there's high level. Look at the mutations. M184V, so something is disturbing me. I don't know how to push it up. Yeah, there is the zoom thing. M184V, K65R. You see those mutations? There are many, but I said don't try to look at many. M14, you know, it's lamivudine, tenofovir, your efavirences are out. That's why your NRTIs are out and your NNRTIs are out. But you see here, this is the old way. They wouldn't test for your integrase if you didn't ask. But my understanding is that now they do. But if it's there on the left form, just tick it anyway so that they do test for your DTG things. Now, you can see on this one, they also did your protease inhibitor. You can see low level resistance to Juranavir, intermediate. And remember now, our third line regimen is reliant on Juranavir. This patient probably was on a lopinavir at some point, but already the third line drug has some low level resistance on it. These are how these results look like. So once you have found something like this, there's resistance, maybe there's resistance as well to your integrase inhibitors, there's that G118R and all those things. Then you must apply, isn't it, to the third line committee. How do you apply? Number one, you need to have all these results, right? They don't within 3 months. You don't have to repeat them if they are there. Full blood count, because these things influence the advice you are going to get. Hepatitis B status, the recent viral load, the recent CD4 count. You send to this email, TLART. TL means third line ART. It's a national thing. And you send per patient. Don't attach 5 patients in one email per patient with the necessary documents. You must complete the form. This is the form. If you want a copy of the actual form, drop us an email, info@clinicalcareplatform.com, and then I will send you the actual form. But your facility should have it, the patient details, the facility, and the doctor and the pharmacy. So if you are a clinic, this is the doctor and the pharmacist at the hospital. These medicines are never delivered at a clinic. It's on a named patient basis. They will be delivered at the hospital. They will be sent to you at a clinic, but the patient doesn't need, if they are stable, they are not sick, it's just the viral load, they don't need to be spending money. Otherwise, they will default even more. All the drug history. If you was on Stavudin 1980, 1990, wherever, you put Stavudin. If you was on Zidovudin monotherapy 81, you put, every history, because the current results, as we look them, will say Zidovudin sensitive. But it's sensitive because currently the patient is not on Zidovudin. But if we know that they failed it in 2004, we know that the mutations are just stored. So we can't give zidovudine even if the result says sensitive. Now, colleagues, are you still with me? I mean, this is administration. I'm dealing with administration. So I'm sorry about that, but I hope you understand that at the end of the day, you're going to do a resistance test. And if it's not done properly, what's the point? And then they say here common reasons for delays from the third line committee: incomplete form. Dr. Mawela's handwriting is very bad. There's no if you don't put the contact details of the doctor and the pharmacist, it will delay. They will write to you. It just wastes a lot of time. Maybe you didn't attach some of you only attached the resistance results. They want everything. Like I showed you, hepatitis B, creatinine, CD4, emails with missing results. So you attach the form without the resistance results, or the results without the form. You attached 5 patients in one email. It's one email per patient, and you didn't tell us whether did you try to resuppress this patient. Did you do A, B, C, D, E, and are they getting resuppressed? Ne? So this is very, very important. So third line drugs in the public sector, I don't know, private, maybe the medical aid decides. The GPs, you would know, maybe there's 848, which is advising, or you are allowed to prescribe them. But here in the public sector, these are prescribed by the third line committee. There's experts, and some provinces have their own third line committees. Like I know KZN has their own, I don't know, probably Western Cape. But the difference, if I was to simplify it for you, the difference between second line or first line and third line is one drug. Say one drug. I hope I can hear you. You are saying one drug. No? Are you saying what drug, colleagues? That drug is what? Duranavir. That is our mainstay. That is our mainstay for third line. And I just want to close by taking you through this particular drug, right? So Duranavir, and remember, uh, lopinavir, ritonavir, atazanavir, mawela navir. If there's a navir, it is a protease inhibitor. Even if you don't know it, Duranavir, so you know that it is a protease inhibitor. It's a very potent protease inhibitor. I won't say a lot about this study. You'll get the recording and you'll listen to it. But this is a study which was trying to determine that this Duranavir, does it work only if it's BD, or can we give it as a daily dose, right? And I just want to show you the results. And the results are exactly what you see. Between pink and blue, there is no difference, right? And the main differentiator is whether your patient has some resistance or not to Duranavir. So if your patient does not have significant mutations and the resistance score is less than 15, that means the drug is still sensitive. You can actually give your patient TLD, for example, with Duranavir as a daily dose. Basically, they are still taking daily everything at night, right? But patients who have some significant mutations cannot be given a daily dose of Duranavir. They need to take the blue one there, which is Duranavir 600 milligrams over 100 milligrams taken twice a day. Remember what we are comparing here: the 800 over 100 as a daily dose versus the 600 over 100 as a BD dose, right? Why is this important? Is because of the side effects. If you look at the pink there, which is your daily dose, it is associated with fewer cholesterol and triglycerides, and therefore lower cardiovascular risk, versus your twice daily dosing in blue there, which is high. So we want, firstly, it is simple, it's daily, but secondly, there's fewer metabolic side effects. So where you can, and even if it's an old patient who's been on third line, but maybe at the time when they were given third line, they had no mutations against Duranavir, you can even simplify the regimen today. A few more slides, colleagues, and then I'm done. It's just on Duranavir. These are the other proteins, but we're talking about third line Duranavir. So we prefer the 800 over 100 milligrams daily. Make sure that there are no mutations against Duranavir. If there are mutations, you can't give the daily dose. You're gonna give the 12 hourly dose, 600 over 100 milligrams. By the way, there are studies that show that if your patient is suppressed, like now you have a patient who's fully suppressed and they have zero mutations, not only can they get a daily dose, you can even reduce the dose to 400 over 100. But for today, let's compare 800 over 100 as a daily dose versus 600 over 100 12 hourly as a BD dose. And these are some of the things you need to do. The other thing about Juranavir, you can't give it with rifampicin at all. There's no double dosing. There's no super boosting. There's nothing like that. You need to get rifabutin to replace rifampicin on your TB treatment. You should never double the dose of Juranavir and saying I'm countering. So these are then the last few slides just to tell you how we make decisions on the drugs. If Juranavir is fully susceptible, that means there's no resistance or there's just a little bit less than 10, the score is less than 10. You can actually, so what usually happens, you have a patient on a DTG-based regimen, they are failing, right? Their third line regimen can actually just be TLD, right? And this would be a person, let me give you an example. You have a patient who's taking tenofovir or zidovudin, lamivudin, and lopinavir, ritonavir. They were fully adherent. They had high viral loads. They were on second line. It's a PI-based regimen. You know, you do the resistance profile. Okay, lopinavir is out, but juranavir is fully susceptible. Okay, juranavir is fully susceptible. But the fact that Juranavir is fully susceptible and this patient was on a PI-based regimen, they've never been on DTG before, just give them TLD. So it means TLD can also be a third line drug, right? This is nice because they would be on TLD as a third line regimen, but we have a backup PI. Should something happen to DTG in the future, we can just give them a regimen that has a Juranavir. So that is the nice thing about it. So bullet one basically is referring to a patient who has never been on DTG. That's the first thing. The second thing is that they have failed their second line. Most likely it's a PI regimen and Juranavir is still susceptible. That's how it works, right? You give them that. Boom. Now, bullet two, if you look at it carefully, it's a patient who has failed second line, right? And this second line, most likely it had a PI like lopinavir, but we kept them failing too long, such that their mutations started to affect juranavir, right? So you can see even before they were on juranavir, they already have significant mutations. So these ones, we give them tenofovir, lamivudin, DTG, but juranavir will be a BD dose, right? Here you don't have a choice of not giving juranavir because it's already compromised. So in the future, it won't work and it will always work with DTG. So we want to do that. If you see a patient who has failed a DTG-based regimen and the Juranavir score is also compromised, there you can't do much. It needs a team of people to review the patient and to make the right call for that patient. Most likely it will be a salvage regimen, still the same regimen like this, but we might need to add another drug, eltraverin, and all those kinds of things. But the concept I need you to grasp is just two things. A patient who has never been on DTG, who fails a PI as a second line. On third line, you can easily use TLD. Someone who fails TLD, they are TLD2 because they've previously failed a PI. You know, so it means here DTG is compromised, your Juranavir is compromised because of the previous PIs. They are likely to get this particular regimen. So most patients are either here or there, right? By lack of a better way. But let me show you what the the clinician society says. You'll see they say a patient who has failed a PI regimen, you know, no prior DTG. You see, if you say no prior DTG, that is good because it means you can just use TLD for that patient, especially if your Juranavir is still susceptible. You keep it as a backbone. That means they have a chance to have a fourth line, right? You give them TLD now as a third line, they suppress. Later, when the viral load is high, they need a fourth line, you can use your Duranave, right? But if the same patient already has a compromised Duranave, you will give them TLD with Duranave. This is from, you see, I love the Clinician Society guidelines because it's a simple, take a picture of it. It's either left or right. Obviously, from a government side, we have this three-color thing. If it's like this, do that. If it's like this, do that. If it's like this, do that. Yo, Dr. Mawela. This one, we can't do much. But this is the national algorithm, and it has taken into account the limitations we have in the. I mean, if you compare this with that, you'll understand why I feel the way I feel about this. I mean, this is it. This is it. I'm not condoning. I'm just teaching as it is, and this is our national algorithm. There's blue. It's a robot. Traffic light. Dr. Leon likes explaining it, but to be honest, if you read it, it tells you the same thing, which is there, right? So then this slide just says if there's a patient on third line, let's say there's a patient on third line, they are taking Duranavir 600 over 112 hours, they are currently suppressed, and their history is that at the time when you gave them this regimen, Duranavir was acceptable. Make it easy. Why must they take 12 hours? You can actually help them to take their TLD with a daily Duranave. So just to say, you can actually make life easy for them. So in closing, I won't ask you to respond. I'm just going to take you through this case. It's a 38-year-old female who has had multiple treatment failures. So this is TLD2, TLD2. Now on TLD for 14 months. The other thing you are getting is excellent adherence. Remember, TLD is a good drug, and then you have excellent adherence. What do you expect? Full suppression. So when you have TLD with excellent adherence and the viral load is high, look at that CD4 count. It means something is wrong. Something is totally wrong here. And most likely there are mutations. The only thing that makes people not to suppress when there is a good adherence and TLD. It's mutations, unless if there's poor absorption of the drugs or those kinds of things, right? So this patient, you evaluate, you'll do your ABCDE, you'll call an expert, discuss to say the current viral load is this, but I have multiple viral loads. It's not yet even 2 years. But we are worried about her, right? A resistance test is done. Look at the mutations. M184V for your lamivudins, we love it. K65R, we note it, but we know science today tells us even if it's there, it's a signature mutation for TDF, but we can recycle TDF as long as it's in a background of a strong third drug like dolutegravir, right? Your protease inhibitors are all sensitive, as they put it there. Wild type means sensitive, right? But remember, there's multiple treatment failures. You might need a drug history. If they were ever on a PI, this sensitive thing here might mean that because currently they are not on a PI, so the mutations are not showing, right? And then also integrase mutations, look at that. I'm sure now you see what's happening. We've got G118R on TLD. I know what you are thinking. It's exactly that. So G11R80 means high level resistance to DTG. E138K on its own is just intermediate resistance. But when you combine it with this one, it would mean that DTG is no longer effective for our patient, right? So immediately you refer her to the third line committee. The most likely regimen, remember here DTG is totally out, so you can't say I'm going to give TLD plus Duranavir. This patient will just get tenofovir, lamivudine with Duranavir. We might need to look for a fourth drug, depending on whether we believe this is fully sensitive and so on. So key points: DTG resistance is rare but serious. G118R is a major DTG resistance mutations. Always refer confirmed DTG resistance to the third line ART. Colleagues, I've tried. I hope that I hope that you got it, because I don't think we will have enough time. Actually, I want to take a picture of you guys. Let me see if I can do it with my phone and say, "Yay, all those hearts, yay, thank you." It means you are happy. Even if I've given you the scope. I know my diploma people, the big exam is coming tomorrow. So I hope, with all those hearts, I hope you guys are, are empowered. Uh, yeah, so uh, let me do this. Yeah, colleagues, that's it for tonight. I hope you have grasped what we have done so far. Thank you. I have been trying Bloemfontein Lab. Apparently, they don't do it. They don't do what, Doctor? Send me a Doctor. There, you have my WhatsApp. Send me a proper thing. They should do a resistance test for your patient, but you need to write your notes properly there with previous riffs sensitive. Doctor, they send me that case via WhatsApp and then we take it from there. Is it possible? Can you touch on oral prep? Not today, but I have said if there is resistance after prep, what must you do? You start your patient on TLD. I mean, if the patient fails prep, you start them on TLD. You do your viral load 3 months on TLD. If they don't suppress, call an expert for a potential resistance test. If they suppress, ne, you continue. So you don't do it before you start. You take note that high risk for failure, and then you give them TLD. If at 3 months your viral load is suppressed, you don't worry. Anytime the viral load is detected, you call an expert, and then we take it from there. All right. Uh does okay, can you pause a bit, colleagues? Now I need to do something, just few seconds, then I will say it for tonight. Just give me a few seconds. I want to help Dr. Magagula for the FCOJ, just for them to start. Yeah, it was going to be a long one. Okay. So I think we are good. He should be able to be there. Give me a few seconds again. Okay, Ncubile. Okay, yeah. So we wait a bit. Yeah, so let me just answer a few questions and then we call it a night. Does myogel or anti-acid affect the absorption of DTG? So the answer is yes. It's not necessarily the myogel itself or the anti-acid, anything that has aluminum or magnesium. It's by complexation. So they attach to the drug, they form complexes. That means the drug won't be absorbed in the tummy. They will have low blood levels of DTG. It will be excreted with the carcass name. Please remind us, Dr. TLD1, TLD2. So I think I covered it. TLD1, it's a, so let's say you are starting a patient on TLD. You have to take proper history. Have you ever been on ARVs? Yes. Have you ever had a high viral load on ARVs? Yes. Have you ever been switched or any drug stopped because you had a high viral load? If they say yes, it's a TLD2 patient. Some patients, you will tell them, you'll ask them, they'll say, no, 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 I've never failed. I'm just new. Go to lab check, go and check them there. You don't have to check all of them when you start, but once someone on TLD has a high viral load, one of the things you must do is to go to the lab system. Then you'll see, Roma, well, I was started in KZN, then he moved to Cape, and today, he's doing, yeah. So that's very important. A TLD1 patient is a treatment naive, brand new patient, right? Um a brand new patient who has never been on ARVs, who has never failed a regimen before, then you classify them as TLD1. It's for risk because later on, when the viral loads are high, that TLD1, TLD2 situation is important. Esther says, in a clinic setup where there is not doctors doing art, can we refer patients? I don't like this thing of refer if they are sick, because someone who has a high viral load, they are not always sick. I would suggest you call the ARV clinic at your hospital. Talk to the doctor. If they authorize the test, you complete the form and you put the doctor's details there. But if you are not finding anyone and maybe the patient is willing to go to the hospital, you can. But please just do make follow-ups and ensure that they get there. Nah. Do private do? Yes, they do, Tamsang. They do resistance testing. Private, there's nothing they don't do. They will even do it when your patient is not on. I'm sorry, they want. I almost said they'll do it for money. No, private, they do it. Sorry, Tamsang. I almost said they'll do it even when not indicated. They'll say, well, you're being nasty. Sorry about that, colleagues. Aroniba says, thank you for such an insightful session. I have noticed an increased number of patients being only on dual therapy, commonly Lomida, irrespective. Yeah, so in South Africa, we don't like that. There is some studies that talk about dual DTG and lamivudine. This should be someone who has zero mutations in the first instance. They should not have the M184V mutation. They should not have hepatitis B. But in the public sector, we don't practice the dual therapy thing. We always prefer triple drug therapy in that space. So talk to the clinicians and make sure that the right patient is on that. There are studies about that, but it's not something we practice because there's a lot of problems with it. I have a patient with a suppressed viral load, but the CD4 count keeps going down. Yes, so those are there. I didn't cover it here. There's a nice algorithm as well in the HIV Clinician Society guidelines. Make sure that it's not Bactrim. Make sure that they are not on something like zidovudine or any other bone marrow suppressing drugs. Check them if they don't have TB because it may suppress the bone marrow or anything that may affect the bone marrow. Check their full blood count. If the white cell count is low, you will never have a high CD4 count because the CD4 count is part of the bigger thing. Doctor, can I change a person from Dumiva with lopinavir to TLD? TLD. Be careful. I spoke about it this week. It must be someone who is suppressed on abacavir and lopinavir. If they are suppressed, change them to TLD. If they are on Dumiva and lopinavir and they are complaining of side effects, and they are suppressed, transition them. What you should be careful of is a patient on lopinavir with good adherence who has a high viral load. Remember, those are the patients you need to do a resistance test before you give them TLD. We need to know whether Duranavir has some resistance or not. Remember, if it has, you can't give them TLD alone. It must be TLD with Duranavir. And clinic, you have switched everyone. Everyone now has been switched to TLD. Even patients who had high viral load on lopinavir, you switch them. The guidelines said if someone is on a lopinavir-based regimen and they have a detectable viral load with good adherence, talk to an expert. Don't just give them TLD. They need a resistance test, as you have seen today. You can't give them TLD only because you are compromising their future. Now, what to do if a patient is on TLD with partial adherence for more than 2 years? Counseling is done. The viral load remains high. Okay. Try to deal with the adherence. Call me, call an expert. We might authorize a resistance test if we feel that the patient is deteriorating, the CD4 count is declining, they might become sick. But the switching of drugs doesn't address adherence. And third line drugs, it's many tablets. The adherence, if you are failing adherence on TLD, how are you going to win when we give you 4 drugs or 5 drugs? You see the challenge. So try to get someone else. If it's a husband, get their wife to come and help them, etc., etc. Does unprotected sex contribute to unsuppressed viral load? I hope Dr. Leon was here. The answer is no. if the person, if I'm living with HIV and I'm on ARVs, and my wife is living with HIV, there's no amount of virus that she can give me that can make me to have 1 million copies on ARVs. If something comes, the virus, the ARVs will deal with it. By the way, the resistant virus is the slowest virus you have. It is less fit. It generally doesn't survive. It's not a virus to worry about. If you are on ARVs. Obviously, if you're talking about an HIV negative person being exposed to an HIV positive person with a resistant bug, there's a likelihood that they may be infected or affected by that. Ne? Can we please look at sudden increase in creatinine? Yeah, okay, that we will do. We had Dr. Jeremy. I'll talk to him if he can come and do that. Doctor, what can I give for someone with a decreasing CD4 count but suppressed in place of Bactrim? Sometimes you don't need to give anything. If the aim is to, if you think the quatrimoxazole is toxic, is the one that's causing that, they can survive without it if they are virologically suppressed. And then there's dapsone, 100 milligrams, if you really need to give them something to prevent PCP. So dapsone, talk to your pharmacist for dapsone, DAPSONE, 100 milligrams. We were told to switch everyone regardless. It was not supposed to be like that. It was not communicated like that. And you'll see if you have switched everyone, especially children, on a Bakave with high viral loads, and you have switched all of them to a DTG based regimen, go and check. There's a big number of them who are not getting suppressed on DTG. They are there. Agribuses like net, but there are many on DTG with high viral loads. And you're asking yourself, they said this drug was going to work. What is the problem? The problem is you gave DTG with a very weak NRTI backbone. Remember, we have studies for TLD. We don't have studies about Abacave. So we have to be very, very careful in that space. Ne? I think super Bunji, I'm happy that you're saying you think, but where's the science to show that if I'm suppressed on TLD and I sleep with someone without a condom who has a high viral load, my viral load is going to go up. I think. So, kidding. It makes sense in the mind, but there's no science. Oh, is Jurana there and not Jura? Is Juranave and not Jura. Amiga utini manje. Please check pronunciation for the drug. It is Juranave and not Jura. It's Juranave. Amiga. Okay, but Amiga, when it comes to English, there I must confirm that I went to Winterfell, somewhere in Northwest. So my English is not the current English, but Juranave. Ah, well, that one I got it. This Juranave. Amiga. Amiga. Okay, guys, I think it's late. Let's who drink too much Coke and energy drinks are not suppressed. No good to it. Now it's Coke. Ay. Colleagues, we have so many reasons why people are not suppressing. What I can tell you, you need to make sure that your patient is empowered, they are treatment literate, they have disclosed, they have the right support, they always have the treatment, and clinically, me and you are doing the right things. They have reminders, Boko kulibo mang mang. Ay, it's not going to work. Doctor, today patient on Lamzit and efavirenz viral load. Yes. So if they're Santos, if they are on NNRTIs, efavirenz or nevirapine, change them to TLD. Those ones, but remember, if the viral load is detectable, classify them as TLD2. So I think that is fine. How do we solve the problem of access of lab results when they are private lab? Yeah, so that one is a minister problem, integration of data between private and public. Okay, I'm going to answer Francina's question. Okay, how do we solve the okay, I think it's that one we can it requires the HAPA people to do data integration. Ne? And then let me see. Francina says a patient with end stage renal failure on TLD or on ALD for more than 2 years and they are adherent but has low level viremia, let's say 500, what do we do? Low level viremia on ALD. You don't have to do anything. If the viral load, if they're on ALD and the viral load has not crossed 1,000, you're not going to do anything. You just keep doing adherence and you repeat the viral load every 6 months because the viral load has not crossed 1,000, right? And you said they are on ALD and they have kidney issues on abacavir, so you are not going to do anything. So they are fine like that. It's only if you can't give abacavir, and the government is going to introduce TEF, which will be another option that you can use. So yeah, I think that's yeah. I think yeah, guys. I've tried to answer all the questions. Ellen Matapelo, you are happy. Huizi Murimo, you are happy. Constance, you are happy. I'm happy that I've answered your questions. I think that is the main things which are there. Okay, DTG resistance. Night, night, guys. God bless you. Bye.